All right, and welcome to the show. This is the Weekly Jargon, and I am Jose Rodriguez.
And Rohi Zachariah.
And today, Rohi, we're absent able, but we'll see him next week. He's out on a business trip. We wish him well.
Yeah.
But the latest news is the Madera Community Hospital finally reopening. And that's going to be our topic today. So if you're joining us, if you'd like to comment, let us know what your thoughts are with this prolonged reopening. I know it's been some time and very much anticipated, but finally we had the reopening yesterday. Rohi?
Yeah, I mean, being there this morning or yesterday morning, it was definitely exciting, a lot of energy. And I know the community that's always been for the last 2 years is, the question is when. And, I think as we were leaving, we were seeing some of the first patients coming in, which were coming from, I think, the state prisons or the corrections. So I think I haven't looked at the latest stats to see how many patients they've taken in overnight, but I'm sure they're back in business, as you would say. So,
and that I think it's a good thing, right? I mean, to see that. We've waited for a long time. There was talks about opening this late last year, early this year, a couple of weeks back, but finally it was done. And yesterday, the CEO Starks made his announcement, appreciated all those folks, stakeholders that were part of making this thing happen. We got our State Senator Caballero, our Assemblywoman Soria, and also we had some words from our County Supervisor Gonzalez. But one thing that was missing was the city. Where were we at right now? We were definitely in the picture, which is great. I think we certainly showed up and represented because, believe it or not, that hospital lies within our city limits. Yeah. And you would say that a good portion of the patients are probably from the city of Madera. Would you agree?
Yeah, and obviously you have the hospital up there in Oakers, which I think in Mariposa as well, that would kind of take care or see some of your folks up in the mountain areas. But definitely, you're going to see the majority of your patients just by population coming from within the city. And like they were stating, I mean, even not just within the city, but even people that are almost within walking distance, that you would get a lot of individuals that would just almost, I won't say walk to the hospital, but that was kind of their mode of transportation,
Yeah, and, I think, when I think about the hospital and the absence of a hospital here in the last almost 2 years, I think, it did cause some effect, especially when people are considering coming and moving to Madera. I mean, they're always looking for, well, what about the healthcare services, right? Where is your community hospital that you had for such a long time? And, we'd hate to see Madera as a pass-through town. Well, I can't be around here because I need these services, especially older folks that are looking to reside in the city of Madera or within the county. I mean, obviously, that's important to them. We do have one of the best children's hospitals here in the nation, and that's out here just east of us, which is Valley Children's Hospital. But again, Children's Hospital. It's not a emergency for any adult folks, intensive care units, or a delivery. And I'm assuming that the closure of this certainly created some impacts with the nearby hospitals as well.
Yeah, and I mean, it was definitely. I mean, obviously, those patients have to go somewhere. They just didn't stop getting medical attention. So you did have longer wait times, filled emergency rooms, in the surrounding hospitals that took on a lot of that load. But I mean, again, it's services at all levels, and that's kind of the thing to remember is even though the hospital is typically, I think in most people's minds, it's an emergency. It's it's critical or dire. But for a lot of people, based off maybe just their insurance or lack of insurance, it was also just their physician, right? I mean, they don't have a regular doctor they're going to. They've been sick for 4 days, throwing up, whatever, and now they need to seek medical attention. And that's where you saw a lot of those patients that now to have to sit and now try and find a means of transportation to another city, again, wait in an even longer line just to be seen. The reopening is hopefully going to kind of shorten a lot of that time down.
And this couldn't come at a worse time, but even with the current administration talking about making some funding cuts to some of these programs that are essential, I think we had some several weeks back, we had some concerns, especially coming from the CEO, Steve Starks, here at the hospital regarding Medicaid. And if Medicaid is cut, Rohi, then obviously that creates a big impact in our community because a lot of the medical system that we have here in the state of California depends on about 60%, according to what CEO Stark said, about 60% of the funding for Medi-Cal. And if we already have issues with reimbursements or low reimbursements, well, you could imagine how much Medicaid can certainly impact our providing the services. So if you don't have that 60% funding, or you cut a good portion of it, then that means less services. And they're highly dependent on, obviously, Medi-Cal being one of the primary health insurance providers.
Well, and that's where the difficulty with the hospital and its surrounding facilities, it's difficult for people to kind of see where I hope they'll make a smart decision going forward. You know, so like I told you, I mean, we worked really close with the hospital for the last 30 years. And, you know, I would say in the last 10, my own self, I was in that ER almost on a daily basis. And I've said this before, but the majority of the people that were seeking treatment were not necessarily in that critical care, meaning that they weren't there because of a broken bone or heart attack. They were people that were, you know, they're sick and definitely in the sick of, like I said, they've been throwing up. They're to the point to where they don't know what else to do. They don't have a regular doctor. But what taxpayers and what the healthcare is looking at is saying, for that individual now to come in, be seen by a doctor, and essentially only receive enough care to basically say, here's some medicine, you know, call us in 2 weeks kind of idea, that treatment costs, you know, it's costing the state, you know, thousands upon thousands of dollars. I think it was like at that time, just for that patient to walk in, it was $3,000. That's what the state funded because of the cost of that hospital care. Where if that patient was to be redirected, for instance, to a clinic or kind of like an urgent care kind of facility, it was much, much less. But the state has strict policies because the hospital tried to do this at one point, and they tried to have, I would say, like educational signage that basically said like, hey, you know, if you're just not feeling well, the clinic is like 30 feet away from you. But the state came in and said, no, if somebody is at your ER door, you have to accept them into the ER. You know, so there's a lot of these things where the idea is good, you know, like the state is trying to say, you know, don't redirect people that they want to come to the ER. But again, on a financial scale, it doesn't make any sense where if I can treat you because you're sick and maybe you just need, like I said, some medicine and a prescription, and that cost is only maybe a couple $100 because you're just paying for that prescription instead of $3,000. It shouldn't be discouraged. That kind of, you know, care should be encouraged. Now, some of that was possible when COVID hit because they had to do a pre-screening area. So before, you know, when you come to the hospital, they would have a pre-screening, and they were able to, I wouldn't say bend the rules, but somewhat pre-evaluate and say, Jose, what are your symptoms? Oh, I'm feeling a little ill. Okay, well, here, we're going to walk you over here. You know what I mean? So there was some of that able to kind of mitigate a lot of those problems.
Yeah,
but that's not there anymore. So
Yeah.
you're going to be in that same problem.
And you know what's funny? What was it? Maybe a couple months back, my son had suffered. Had a what we thought was a symptoms from a flu, right?
Mm-hmm.
And obviously, being that he was getting these fevers and, you know, up and down, we wanted to make sure, hey, maybe we got to get to see your doctor, right?
Sure.
So, you know, it got to a point where his fever was a little high, he wasn't feeling good. So where do I go, right? I can't call his doctor and say, hey, I need to make an appointment, because sometimes, obviously, those require appointments.
Correct.
So then we don't have a hospital here. So, you know, obviously, like a concerned parent, I take him over to Valley Children's Hospital. They admit us in there. And as we're waiting on the waiting room, I mean, there's quite a bit of people that have similar symptoms. Mm-hmm. So I asked a patient that was there, you know, they all had their bracelets, and I'm assuming they're coded to see who's mild and who's needs priority. Yeah. So I asked how long they were waiting, and surprisingly, it was about 4 hours. So I ended up leaving, and I said, I think we can probably nurse you here for the next couple of hours until you have your meeting, your appointment in the morning. But the fact that there was not a hospital, and an emergency seems the right way to go because you want to take care of the issue right there and then. But the preventative measures that you're talking about could be easily mitigated so that you're not going through this ER process and expending so much dollars through our system already that sometimes that's what keeps these hospitals sometimes in the red is the fact that they're needing reimbursements for the services, but yet it's really hard to gain them from the health insurance that they currently have.
Yeah.
So I wanted to bring up this is from the Fresno Bee, just showing us a chart, Rohi, if you will, mainly just giving us 8 different counties in the San Joaquin Valley that benefit from the Medi-Cal system here in California. And as we read through these, we look at Fresno, for example, with the population of over 500,000. They're at the top. Well, not at the top, but close to the top there. I think they come in 3rd place there with 53% of its residents that depend on Medi-Cal. And Madera, obviously with us, there is a 51%, which is still high. That tells you that it's, that's more than half of the population that may have some form of Medi-Cal service and or they're recipients of that funding. So what's scary is that, although there is 4.4 million people within those 8 counties, it says there are 2.2 million. And you could imagine that even a 30% haircut on Medicaid can certainly have an impact on a lot of these hospitals that are already struggling. It was a lot of work that both the state senator and assembly member, the governor, and all those folks out in the state legislature that put this thing together to come to find out that may not be enough. If Medicaid is out, then obviously we're going to need additional funding to be able to, continue this healthcare system that we have. Now, that being said, Rohi, do you feel that, or maybe ask you what your thoughts are on a healthcare system for Californians? Obviously, we have the Affordable Care Act for the nation, but our system of it that we have here, do you feel that it's an adequate program to meet the needs of a lot of these folks that can't afford the private insurance?
Yeah. I think, and then this is coming just from what I can say, like I said, seeing directly from those services. I think first off, and this is coming from insurance in general, is that Americans are not as healthy as we were 10 and 15 years ago. It's eating a donut this morning, and it was very delicious.
Who's eating a donut?
But I think that it's got to be addressed to say that Americans are just not healthy. Because again, like I was trying to explain to you, is when you look at what they're there for. Yes, there's definitely the people that are there for, especially the last couple of years, COVID and COVID-like disease and heart attack and just some of these prolonged diseases that again go with our health. But then it's identifying, like you said earlier, it's my kid, he's been sick. What can I do? And it's some of that helplessness, I would kind of say, is like I can't figure out what to do. Now for us, the way I know to us people think we're crazy, but I don't really take a whole lot of medicine. If I get sick, I let it ride out. I try to do the natural, holistic whatever, right? You ride it out, right? But by doing that, I've made my immune system much healthier. I don't get sick. I don't really miss days of work except the few days that we missed during COVID. And I would say that unfortunately that is where I think healthcare as a business is falling apart because again, I'm an insured person. I have good insurance, but I don't use it. So the hospital would love me as a patient to come in there for the next month for a health-related disease and get full reimbursement, but I'm not taking advantage of it. And I think that's been some of that push in healthcare, and that's why you kind of see like Kaiser and stuff was doing a lot of these ads promoting healthy environments and trying to get people up on their personal health because again, the health insurance program as a whole is a losing battle. If people are just constantly in the hospital for things that were, I guess you would say somewhat preventive because a lot of it has to do with obesity, what they're eating, they're just their lifestyle. Maybe they're staying up late, not getting a lot of rest. These things that are, would fight disease. it's just not going to be sustainable, whatever you put it at. Because again, that insurance program, Medicaid, Medi-Cal, all these things, you have to have people putting into it to make it fundable. Just like your social programs, like your Social Security program. I mean, like if more people are staying alive longer and there's not enough money, it's the same problem. So I think to address it is really going back to the core and saying, how do we make Americans healthier and having them use the hospital less? But again, at the same time, the hospital doesn't make money unless it's got patients, but it needs patients that are going to be on health care.
Yeah, no, and totally, that makes a lot of sense there. And one thing that we did talk about not too long ago was regarding what sectors of the economy or industry are rising, right? And the health professional industry was making a jump on there, aside from the private schools and then government jobs, right?
Correct.
That's where you saw most of this employment. And I can see why, because it's a very, I'm not going to say lucrative, but it can be pretty expensive. And as insurances premiums continue to go up, obviously, I mean, who's making the money behind those premiums, right? Obviously, you're paying premiums because claims are starting to come in. So if I go to the hospital, Rohi, for an annual preventative care, obviously there's a cost for it, right? And part of that cost is covered through your insurance. Not having to pay for that, it's a good feeling. I mean, obviously, that if you pay a small co-payment, then hey, I just want to make sure that my vitals, everything's good on my end. This is a preventative way of me developing some chronic disease that can certainly cost society a lot of money, right? So I think knowing that we have that insurance, I think it makes us feel safe, the peace of mind. But you'd be surprised how many people don't have that. And I think that's where, you have these last minute, well, I just found out I have stage 4.
Correct.
I just found out that I have diabetes. I've had it for so many years, or I'm suffering. But you're right. Americans, by far, are falling way below the health chart there as far as healthy.
Yeah.
And obviously it could be certain regions. Regions may have better, like certain areas that have a lot of, that are affluent families that really prioritize care and health. But then you have 50%, in this case, in our counties where you have, a lot of recipients that are recipients of Medi-Cal. And I don't know if there's a correlation there that, hey, poverty equals to low, health issues, right? And maybe because to the extent that you're eating a lot unhealthier means, right? You're eating very unhealthy, and therefore you're developing these particular diseases.
Yeah, I think that's 100% the problem. I mean, the joke has always been, it's $15 for a salad, but you can go get a hamburger for $3, So if you got money in your pocket, are you going to get the hamburger that's going to satisfy your craving, or are you going to pay 5 times that amount to get some leafy greens that you're still going to be hungry at the end, but obviously contain a lot more vital nutrients that you need as a human,
Yeah.
So, and that goes along the whole spectrum. There was one of the articles that came up on my phone the other day was, a lady who bought, she was buying the king crab from Costco, and it was like $500 for, 10 pounds of crab. And you go, like, because fish is supposed to be, one of your healthy dietary foods, and fish has become unattainable to some degree. Like if you were to go get fresh, farmed, nasty fish, you can't afford it as an average person. It's become now, and I don't know if that's by design. I mean, you can put your conspiracy helmet on and say, like, maybe it's by design. Maybe we only want the rich to be able to have that healthy diet, and we're going to push the poverty ones and make them sick and dependent on the system. There could be that craziness.
Yeah.
But yeah, as a person that says I want to make healthy choices, it doesn't become cheaper. It becomes vastly more expensive.
Yeah, and I hate to go down a different route, but you know what, Rohi, you brought up a good point, because even fish nowadays, looking at they call this 8th continent now, because it's so big now, where all this plastic kind of comes together, right? And this mass of plastic that's out there in the sea.
Garbage patch,
Yep, exactly. And to some extent, maybe the fish that we're eating today also may contain some form of plastic, right, to a certain micro scale. But, even that, I mean, think about it. It's just like everything that we have with the growth of our population, the industrial revolution, and what we've been able to create, obviously, the ability to gain our food through these particular resources and these efforts that we've done, advanced technology, sometimes, it makes it easier for us to eat bad, right? To have unhealthy choices. And, just the fact that we have sugar at a high level, we have sodium at a high level, we have fats, and some of these are hydrogenated fats that are really bad for you. Obviously,
sure.
some of these synthetic oils that that harden up and become hydrogenated.
Yeah.
There you go, and those are bad for us, right?
Sure.
I mean, so there's
But
a
they
lot of
taste so
different.
good.
Yeah, it tastes so good. You can't believe it's not butter, right? That was the deal there. But I mean, it's getting to a point where, I mean, Americans, like you said, are getting so unhealthy, and more of them, because they're on the lower income scale, are dependent on these services such as Medi-Cal.
Yeah.
And again, has an effect, as we're looking through these counties, has an effect on the reimbursement, because in order for these hospitals, especially within the Central Valley, you could imagine if a lot of these hospitals depend on that depend on the funds for the reimbursements from Medi-Cal, then they could be at the brink of just saying, "Hey, I can't make it anymore if this funding is cut."
But that I mean, again, that's where I'm saying let's say for the next, because the hospital opened like 24 hours ago. I mean, in 15 minutes, let's say 24 hours ago, and obviously you didn't have, I can't remember how many beds they can service, but you didn't have 300 people knocking at their door ready to fill every single one of those beds. So they're going to have a ramping up process, obviously, before they're at any kind of capacity. The question is going to be, is what capacity do they want to be in? Do they want to be a primarily, self-insured customer? Of course they do. I mean, that's where, when you look at the business, that's where the money is. You want to they would love to be at 100%. Everybody walking in that door has, the platinum plan insurance, because then they become sustainable. I think that model, like you said, I mean, with 50% of the population already not on that any kind of insurance, it's also looking at who's taking advantage of that program. The majority of those people in that hospital are not going to be insured. They're going to be, so really the hospital, so it's actually much worse, because you're saying, 50% of the population of the city, but the population that's going to be actually coming to the hospital is probably going to be much higher. It's going to be like 80, 90% of that population is those people that are going to be uninsured. Because again, unfortunately, when it comes to Medicare or just any kind of medical help, if I have the greatest insurance and I have to choose between, for instance, Madera versus, I think it's like Clovis, that maybe has a little bit better resources or facilities, maybe they just look prettier, most people are choosing that. They're going to say, well, I have a choice. I'm not dying right now, so I mean, I can make that drive, or I can get an ambulance and get it over there. I'm going to take my care where I feel my money is best spent, because I have insurance. And that's where that model has to also change a little bit. You're going to have to encourage the people that are going to fund your hospital, those fully insured individuals, to also be customers of your hospital.
Yeah, like in any business plan, I think you have to consider obviously private insurance as a major source of your income, because if you're dependent on solely on just the Medi-Cal reimbursements, and I think you could be in trouble, right? So you have to, I think as a business plan, you're trying to, you'd be surprised how many folks with the city, the Unified School District, and even the county government have private insurance, right? But sometimes choose not to utilize your local community hospitals, and they'd rather go out to where you said, right?
Yeah.
I mean, Kaiser but I mean, here's where I think, you can make a difference. I think, that if you rely on your local community hospital, again, preventative measures, you're not there really you have your doctors, right? Your doctors within that circle, but at the same time, screening, radiology, stuff like that, you have a hospital that can take care of them, facilitate a lot of that, So if you add the business there, it's no different than when we talk about the sales tax, right? If you're taking your money and it's being spent in different counties or different cities, and obviously none of that money is being recycled back into our community.
Yeah.
And I think the reason we fought hard for this is to let people know, hey, we have a community hospital. We have a good set of doctors here, that will certainly provide the care that's needed. It's not only for those Medi-Cal recipients. And I think that's the message that we have to deliver, is that we have a really good quality hospital here. Again, the American Advanced Management Group, that's what they're promising to bring. Yes, we're going to reopen it with some of the state funding that we have, that was brought by, again, the state legislatures like Senator Caballero and Esmeralda Soria. I know I'm saying that over and over.
Sure.
Not that I'm trying to promote them, but because of them, we have this reopening again, because of that legislature that passed to allow for the funding or loans made to these distressed hospitals.
Yeah.
But anyhow,
yeah.
We want to see our community, and it was a proud moment for a lot of us. It was a very happy moment for others. But we definitely want to see the participation rates in a lot of our recipients or people that get good private health insurance, right? I mean, who doesn't want to do that? I mean, both of my kids were delivered at Madera Community Hospital. I'm very proud of it because my wife and I, we spoke very highly. We were like, wow, they took care of my wife, took care of our kids, and took care of me. While I was there waiting with my wife, I felt like I was very, the service was great. I mean, obviously you heard of some horror stories, but again, these are one-off sometimes. I don't know that if they wanted to chime in and make comments on it, tell us about your experience with the hospital before. I mean, obviously, we'll start seeing moving forward what that looks like, but tell us how you experienced Madera Community Hospital. What were your experiences?
Yeah, and I think, again, the short-term concern, it needs to be said, which is, they're gonna be in a battleground in the sense of that, for that turnkey as of yesterday. Obviously, it's been costing money leading up to it, but you have a real expense now. You have staff on hand that have to, by state law, be on hand, whether one person uses it or 100 people are using it. So their expense clock is already going, and that time to reimbursement, it doesn't also happen immediately either. So that person that came in at 10:01, got treatment, is Medicaid, Medicare, whatever, even private insurance. It's the hospital has spent that money because of staffing and equipment and whatever, and the delay to getting payment is obviously going to be there as well. And this is with any business, that you're going to have. And I think that's my concern is for, until they can ramp up, they're going to be unfortunately really spending at a loss because they're not going to have the population. But like you said, it's what population are they wanting? They need to have that encouragement of those good customers to not just come in for a Tylenol, but to have that extended stay, so that's where they're going to make their money.
Yeah. So Rohi, and I'll jump into this because I think it's important to state. But now that health services or hospitals, for this matter, are this is a private company working with a nonprofit organization to try to bring, services to our community, right? And I think the state, our counties, they're starting to go through this privatization of companies that understand that, hey, in order to get a business done, this is the model that we must follow in order for you to be on the black and avoid dipping in the red, right? Yeah. So it sucks because a lot of the private companies, and I'm not bashing on this particular one, but it's happening, and this is why Doge is becoming such a big topic of conversation, is the efficiencies of government have obviously put a strain on the deficits that we have today, right? And this is an example of how, I don't know, prior to this, you still had a nonprofit organization running the situation, right? Yeah. Obviously, there's state funding. It's a private public partnership, but it seems like we're certainly yielding rights more to the private side. And when I think of private side, I do think it's efficient, but it also owes a big loyalty to its investors, right? So I don't know if this particular unit has a symbol and the stock exchange. But obviously, when that's of concern to me, because then it's trying to maximize profits for its investors, right? And I don't know that this particular service sector, like the healthcare, is one of those, especially when it comes to like community hospitals and what have you. But I mean, in general, where did we stop being efficient as a public agency or as a government for the benefit of the people? Because if you look at the extreme costs it takes to really take care of folks when you have Social Security, Medi-Cal, or anything that has to do with government, did we just say, hey, I'm just going to show up to work and I'm not going to care about the efficiency of this system and just, just get paid?
Yeah.
And essentially, I think the state has gone to a point where it says, hey, we can't, this is no longer sustainable. So,
yeah, I think in that, that when you bring up efficiency, I think it's always best to look at that. I mean, if you look in the city, there are private doctors that have private practices. And again, they don't always accept insurance only. They take on anybody, but they're sustainable and they're making money. And they've been making money, they're paying their staff, they're paying themselves, the building, all of these things, and they're remaining profitable. So like you've always said, is that the economic scale should say that, well, if the scale, efficiency should kick in with the hospital and say, well, if we just do what they're doing at a much grander scale, it should be even more profitable because again, now I can have the same amount of staff servicing even more individuals. But it doesn't work. There's something that's broken in there that has to be looked at, like you said, to say, why can this individual place remain completely profitable and very profitable, and our hospital's running at a complete loss? That there's got to be some of that middle ground, and I know again, like we were talking about a little earlier. I mean, that middle ground are those clinics because again, clinics are a lot cheaper to run, and they're dealing with the health, the care needs that are not in that emergency status. So, when you have like things like the Camarena centers and even the hospital at one point had their own clinic, that's where their money is made. That's where they're making the most profits because again, the cost of care to see that individual is much, much less than it is when you start sticking them into an emergency room. Now, the state doesn't allow that type of business to be influenced. Like we said, if I'm coming in and I have a cough and again I don't have a primary doctor, so I'm coming to the ER. It should be encouraged that those individuals use the cheaper care, the cheaper to the state, the cheaper to everybody, still getting the same care. They're still getting well, they're still getting seen, they're still getting the medicine they need. But if it's costing maybe them a couple $100 versus a couple $1,000 because they're going into the ER, that shouldn't be, it shouldn't be looked at as a negative thing. That should be the encouragement. But again, through state policy, that's not the way it works.
Yeah, no, and I totally agree there, Rohi. But I feel like there's been a like this period of time where we've lost the art of being very efficient when it comes to like spending money. I think, I'm not saying the art, but I think those principles of making something sustainable have kind of just faded away slowly. And I mean, as government, I think we haven't really put an end to like, well, where are we no longer efficient? At what point are we no longer holding ourselves accountable to be efficient to the public's money, right? And I think these are the conversations that people are having today. I think they can be taken to an extreme though, because these are essential services. These are very essential services. And I'll just go back in some history, right? Like in the late 1800s, you probably didn't hear of Social Security systems, or you didn't hear of medical health programs and stuff. This didn't happen until during the Great Depression, right? You started seeing Social Security come about. And then we started seeing that, hey, health services should be an essential right for people. We should be able to again, we started uniting our nation more of a, working together with all these states. We started becoming very efficient. Income taxes are being, funneled up to the government. Government then is starting to split and saying, hey, we're going to give you this, we're going to give you that, transportation dollars, Social Security dollars. All these social programs became essential for the Union or for the United States, and then it started dishing off the funds accordingly based on the need and or population or maybe income needs, whatever the case may be. California always being a big donor of that. But I mean, you look at our education system also. To some extent, people may start questioning whether or not our education system, especially public education, is efficient and or is it really reliable now? I mean, and I don't want to use the word reliable. We're falling below the charts of our education system, right? And in certain cases, it's not everywhere, but when we see it, our numbers, especially within our valleys here, maybe it's not becoming very efficient. And what's happening? What happened to the accountability piece?
Yeah.
Are we just recipients of state and government funds, and we no longer want to hold ourselves accountable to the measures of what other countries are doing? Mm-hmm. What is it? Is it the hegemony? There's got to be something, right?
Insurance is always a fun word because, again, you can get insurance on everything. Now you can get insurance on your washing machine. You can get insurance on your car, And I think if you were to say, like, how do I make insurance, the word, more affordable? I think you would have to say, have the state or the government, Fed, whatever level, approach it like anything. Have it be a source of consolidation, meaning that I need insurance as an individual on many aspects of my life. I need it on my cars. I need it on my house. I need it on my health. And offer some form of government program for that's covered as a single unit of insurance. Okay, and by doing that, just like efficiency would say, that would mean less staffing because now I don't have a health care insurance, I don't have a home insurance, I don't have an auto insurance. It would just be one insurance, one program. And I say that because when you look at, insurance, for instance, on my car, the car insurance, there's no freebie insurance for those that are poor. It's still required for them to have it. And because some of those people don't have it, if I run into them or they run into me, now I have to have uninsured motorist coverage, right? Which costs me even more as a policyholder of insurance. So insurance as a whole should be looked at when you say, like, people need insurance. They need everybody needs car insurance. If you drive a car, it should be already baked in. There shouldn't even be the question of an uninsured motorist or an uninsured individual when it comes to healthcare or their house or anything in that aspect. But you can make that affordable by just, again, packaging it as an individual. Jose is covered in every aspect of his life.
Yeah.
And have a moving scale that says, well, okay, like they try to do, you make so much money, you have so many risk assessments because you got a house and this is what your car is worth and whatever, and move that scale to say, Jose, the United States of America is going to offer you this insurance program for Jose and cover you,
Yeah.
But everybody would have it.
But
and it would be one program.
I do like, when we would talk about the competitiveness of our